My name's James Aitken, and I'm the Clinical Director of the Western Australian Audit of Surgical Mortality, which is part of the ANZ Audit of Surgical Mortality. This year, ANZASM is holding a series of national seminars, each which has been organised by the different states, and it's WA's turn today. An important event occurred last year, which was when the Commission published its updated framework for clinical quality registers. One of the longest running clinical quality registers in Australia has been the hip fracture audit. And after discussion, the hip fracture audit agreed to present tonight the lessons that they've learned during the course of the last few years, notably that they have had clinical care standards for hip fracture, which have also been updated fairly recently. At the moment, the Commission is developing clinical care standards for emergency laparotomy, and between them, a fractured hip and emergency laparotomy account for about 60% of all the deaths in the hip fracture audit, so in ANZASM. So there's a lot to learn. So I'm just going to give a few housekeeping points, and then I'm going to hand over to Chris to chair the rest of the meeting. This meeting will be recorded, and it will shortly be placed online so that you can go back and look at it and other people can turn up. When you're not talking, please have your microphone on silent so there's no cross-contamination. If you've got questions, we'll take them all at the end, but as we go through the presentations, if you want to put them in the chat room, that's fine. During the course of the meeting, we'll collate them, and at the end, there'll be plenty of opportunities to have a discussion. So with that, I'm going to hand over to Chris Wall, who is the co-chair of the ANZ Hip Fracture Registry. Chris.
Well, good evening, everyone. My name's Chris Wall. I'm an orthopaedic surgeon from Toowoomba in southeast Queensland, and I'm also the co-chair for the ANZ Hip Fracture Registry. And we're really delighted to have been invited to present this evening by the WA Audit of Surgical Mortality on lessons from clinical quality registries. We've put together a series of talks which we hope will be of interest to a broad audience, acknowledging that there is a slight orthopaedic flavour to the evening. Before I start, I'd like to acknowledge the traditional owners of the lands on which we're all meeting. I'm coming to you from the land of the Jarrawera and Guyable people in Toowoomba, and I'd like to pay respects to elders past, present and emerging, and I'd like to make a particularly warm welcome to all First Nations colleagues joining us this evening. Here are my declarations. So as has already been mentioned, the ANZ Hip Fracture Registry was established over a decade ago, and our vision is to be an exemplar clinical quality registry, driving excellence in the dignified care of older people following a hip fracture. Our purpose is to use data to continually improve patient care, outcomes and experience following their hip fracture. And we want to achieve that by having high quality data, achieving better care, amplifying the consumer voice, and also facilitating advocacy and engagement. As James mentioned, the Australian Commission on Safety and Quality in Healthcare has released a series of clinical care standards, and one of these is the Hip Fracture Clinical Care Standard. This was first released in 2016, and the Hip Fracture Registry was really established alongside the Clinical Care Standard and reports on data for each of the quality indicators in the standard. Some of you may be aware that in September 2023, an updated standard was released, and we have now updated our data set to collect data relating to the indicators in the new updated standard. And this year, in 2025, we'll be reporting against this new standard. The clinical care standard includes 7 quality statements and 16 quality indicators. And my colleague, Professor Jackie Close, will be talking more to this in her talk. But just to briefly introduce it, the Hip Fracture Clinical Care Standard has 7 quality statements, and these revolve around care at presentation, pain management, an orthogeriatric model of care, timing of surgery, mobilisation and weight bearing following surgery, minimising the risk of another fracture, and transition from hospital care. Now, the ANZ Hip Fracture Registry has participants across Australia and New Zealand. In fact, we have all eligible hospitals in New Zealand participating and submitting data, and we have 86% of eligible Australian public hospitals submitting data. We also have a small number of private hospitals involved in Australia, and we'd love to increase the proportion of both public and private hospitals in Australia. So if you are in a position of influence in your hospital, please do advocate to get involved with the Hip Fracture Registry. In terms of the patients for whom we collect data, as you'd imagine, the majority are female, so about 2/3 in both Australia and New Zealand. The majority are elderly, so the mean age of 81 years in Australia and 82 years in New Zealand. The majority, so nearly 3/4, live at home prior to their injury. Around 40% of patients had a pre-existing cognitive impairment or known dementia prior to their injury, and just under half walked without a walking aid prior to their injury. Each year we publish an annual report, and in fact this year we'll be publishing our 10th edition or 10th anniversary edition, which is a really exciting milestone for the Hip Fracture Registry. And the annual report reports on a hospital's performance against those quality indicators in the clinical care standard. Last year, we added an additional 17,700 records for patients cared for at 100 hospitals across Australia and New Zealand. And the registry now has data for over 120,000 patients. As you can see, we record data points across the patient journey from admission right through to discharge and also to 120 days post-discharge. In this infographic, green dots represent areas where there has been improvement in performance on previous years. Blue dots represent areas where there has been no change in performance on previous years, and red dots represent areas where there has been a decline in performance, and these are areas particularly we need to be focusing on. We also present data in the form of caterpillar charts, and this allows hospitals to compare their performance to the national average. So this is an orthopaedic example. So this is a proportion of patients who have surgery within 48 hours after presentation for their hip fracture. So in the original hip fracture clinical care standard, the goal was to get patients to theatre within 48 hours. And in Australia, 76% of patients achieve that benchmark and 80% in New Zealand achieve that benchmark. And you can look at your the caterpillar chart and figure out where your hospital performs, whether it's below average, at average, or above average. The updated clinical care standard now has the benchmark or the target at 36 hours following presentation. And this has been a sort of significant challenge for all of us involved in hip fracture care. And in this year's annual report, we'll report on the 36-hour target. We also look at reasons for delay to theatre. And if you look at the light blue, you can see that the most common reason for delay to theatre in both Australia and New Zealand is a theatre inavailability. And we feel that's a really unacceptable reason not to operate on a patient in a timely fashion. So all of us involved in hip fracture care really need to be advocating for access to theatre so that we can ensure that our patients receive timely and appropriate surgical care. In the yellow, you'll notice that a proportion of patients are delayed due to issues with anticoagulation. And my colleague, Dr. Seth Tarrant, who's an orthopaedic surgeon from Newcastle, will be talking to this shortly. But again, this isn't actually a valid reason to delay surgery anymore. And you'll also note that the dark blue there is patients that are deemed medically unfit for surgery. And I think it's really important that we critically assess this to ensure that patients are only delayed if there is a medical intervention that is going to optimise them. And we don't want this just to be an excuse for delaying access to theatre. So these are all areas that we need to be mindful of and addressing. Each year, in addition to our annual report, we also publish a supplementary report. Both of these documents are freely available on the internet. And the supplementary report goes into much more granular detail as well as doing a state-by-state comparison. And here are some examples from the supplementary report, again, looking at some orthopaedic data. So on the left-hand side, we have the proportion of patients who have received hemiarthroplasty in light blue compared to total hip arthroplasty in grey for displaced intracapsular neck of femur fractures. And it's interesting to note the variation across the two countries in treatment options. On the right-hand side, we have the use of cement in hemiarthroplasty for hip fracture care. Now, there are clearly documented national and international guidelines stating that we should be using cemented fixation for femoral stems in hip fractures. And you can see that the majority of hospitals in Australia and New Zealand use cement in the majority of cases, which is great. In addition to our regular annual reports, we also conduct sprint audits, and these are focusing on specific aspects of hip fracture care. So in the past, we've looked at nutrition, bone protection medication, acute rehabilitation, and preoperative fasting. Last year, we looked at direct oral anticoagulants, and Seth's going to present the results of that sprint audit shortly. And this year, we're about to start a sprint audit looking at pain management. So we look forward to bringing you those results in due course. We're also actively involved with research, and to date, there have been over 30 publications in the international peer-reviewed literature using registry data, and we have another 20 projects currently underway. We're very keen to engage with interested researchers, so if that's you, please check out these websites and please get in touch. We'd love to hear from you. And finally, a bit of a shameless plug, I'd like to invite you to our annual Hip Fest. This year we'll be holding it in Melbourne in November. This is an annual event that we run that brings together stakeholders in hip fracture care from across the country. It's a wonderful event. We had around 200 delegates last year in Sydney, and we'd love to see you in Melbourne. So please jump on the website and register. It is a free event, and we will look forward to seeing you there. With that, I will stop sharing and I'll hand over to my colleague, Professor Jackie Close. Jackie.
All right, thank you very much, Chris. I'm Jackie Close. I'm a geriatrician based in Sydney in New South Wales. Many of you have been aware of the Hip Fracture Registry for a number of years, and of course, it's not a novel intervention or a novel application. The registry is very much based on the UK NHFD. When I say UK, I actually mean England, Wales and Northern Ireland. They set up their registry in 2007. And it was based on a set of standards. The standards for their registry were a combination of the British Orthopaedic Association and the British Geriatric Association coming together and creating what's called the Blue Book. I know the Blue Book in Australia means something different, but in the UK, the Blue Book to most of us was very much the recommendations for hip fracture care. In 2015, this paper was published, and it was an external review of the impact of the registry led by the College of Surgeons, and its 30-day mortality. And what you can see over here is in 2003, 2004, 30-day mortality was up towards 12%, but it was already coming down over time before the actual launch of the Hip Fracture Registry. What you do see, though, with the launch of the registry is that annual decrease in mortality is more significant. So there was some early evidence from the UK NHFD that the registry was potentially impactful in terms of saving lives. This is actually from Matt Costa's group in Oxford and is slightly different in that in addition to setting up the registry in the UK, or England, Wales and Northern Ireland, there was also the introduction in 2010 of a financial incentive, so that if you delivered against 6 predetermined standards that were in the Blue Book, there was a financial incentive that came with that. There was a natural control in the UK in that Scotland didn't have the standard and nor did it introduce the financial incentive. So when you look at the recommendations there from the Blue Books, they're very similar to what we do here. So admission under joint care between orthopaedics and geriatrics, multidisciplinary assessment, surgery within 36 hours, geriatrician review, multi-professional rehabilitation and assessment for falls and bone health. Now, the black dots are Scotland. And so over time, there was a reduction in mortality in Scotland. Here's the introduction of the incentive, and you start to see England diverging from Scotland, suggesting that not only is there a benefit from the introduction of the standards, but the financial incentives also confer a survival benefit. Chris has already highlighted our journey in terms of a guideline. So it's an Australian-New Zealand guideline. The original clinical care standard was published by the Commission in 2016 and last updated in 2023 with a set of quality indicators that we report against each year. This is the most up-to-date one. I was looking through this list when I was putting these slides together. The College of Surgeons isn't actually on this list, which is a little bit of a surprise. I'm not sure what happened there. But I guess the question, and one of the questions you need to ask of a registry is, are we actually making a difference? It's all well and good having people collecting all this data, but is it driving change? And there are no shortage. The health system is awash with guidelines and policies and standards. So is this clinical care standard that we're all striving to achieve, does it actually confer benefits to the patients that we treat? So this was published as a paper published, Lara Harvey is the first author, published in the MJA towards the end of last year. And it's looking at exactly that. If you adhere to our clinical care standards in Australia, this happens to be New South Wales based, if you adhere to the clinical care standards, are you better off as a result? So we looked at, and it was just New South Wales data that we had at that particular time. We now have the whole country to be able to look at this data, but this is for New South Wales to start with, between January 2015 and the end of December 2018. And we were able to link the hip fracture registry data to hospitalisation data, residential aged care data and death data. And in the end, there were 9,500 hip fractures, 9,336 individuals. And in terms of what we had available, complete case analysis, it was 7,900. So if we look and see how we do against, and we looked at the acute care indicators for the purposes of this particular study. So actually orthogeriatric co-management is very common in Australia. It is kind of the norm now. This is surgery within 48 hours. Of course, that's now changed to 36 hours, making it a little more challenging, but still the right thing to do for patients. About 3/4 of patients get surgery within 48 hours. Early mobilisation. This is an important one to note. So early mobilisation, the definition has now changed. This was literally that the patient was offered mobilisation. We are now much stricter with that recommendation, and basically bum has to leave bed to be able to score on that particular one. Unrestricted weight bearing, the vast majority of patients are allowed to, weight bearers tolerated. Don't sustain a pressure injury. And here's where we are particularly bad. And even with the updated data, we're still sitting around 35% in terms of patients leaving hospital on treatment for osteoporosis, despite the fact they're sitting under our noses with an osteoporotic fracture. We then looked at those patients who achieved anywhere between 0 and 3 indicators, those patients who scored on 4 indicators, and those patients who had 5 or 6 indicators. Only 7%, and in fact it was less than that, 3% of patients actually scored on all 6 indicators. And when you compare low adherence to moderate and high adherence, if we just look at the individual measures, you can see there is a clear survival benefit in terms of adhering to these particular standards. I think probably one of the most important ones is the early mobilisation, very tight confidence intervals and benefit. When you look at moderate adherence and high adherence, so if a patient achieves adherence to 5 or 6 of the 6 indicators, that's a very significant survival benefit, and that is adjusted. That's the graph I've just showed you on the previous slide. This is 120 days. This is 1 year. And you can see the graphs all look very similar. That benefit is sustained over a 1-year period. And here's it demonstrated differently. 30-day mortality, low adherence, moderate adherence, high adherence, and the same with 120 and 360. The pattern is consistent. Death isn't the only important outcome, and most individuals would tell you that actually being alive, at home, and as independent as possible is probably as important. We've started to look at days alive at home at 120 days as one of our patient-centered measures for the registry. It's not a new outcome measure. It's reported in the perioperative medicine literature. It's been used for elective arthroplasty, but it's usually days alive at home at 30. And in terms of just describing how you calculate it, so of a 30-day period for somebody who's come in for a hip replacement, you take away the total length of hospital stay, which hopefully is only about 2 or 3 days. If they end up back in hospital for any reason during that 30 days, that comes off 30. If they end up in a nursing home, whatever number of days they've spent in a nursing home, that gets taken off the 30 days. And if they die, of course, then that also gets taken off. So that's how you calculate it. There's been some evidence for using days alive at home at 90 in a hip fracture population. We use 120 days as our follow-up period for the hip fracture registry. So we've started to explore what it looks like. If you adhere to the clinical care standards, are you more likely to spend more time at home? Because that is what patients tell us matters. This will be a little bit unusual in terms of a diagram, so bear with me. These are the numbers of days spent at home, and you want to be over here. This is people living, or these are people living both in residential aged care and in the community. So over here, this spike that we see is almost certainly people, and when we have actually looked at it, these are the people who come from residential aged care who get sent back to residential aged care quite quickly. So that's what causes that spike. Over here, these are people who never get home again. They either die, but the bigger percentage there is the people who were originally in the community and end up in residential aged care. And what we find is the median time spent at home of a 120-day period after hip fracture is 86 days. Low adherence is 69 days, moderate is 84 days, and high adherence is 88 days. The bottom line is if people receive high quality care as defined by those indicators, they're more likely to spend more time at home. Just going to finish on the idea of financial incentives. I've showed you how it worked in the UK. It has been explored in WA. It was introduced a number of years ago now. Hannah Seymour was part of this. There was a small amount of money provided, a few $100s at the most, for hospitals each time they adhered to 6 quality indicators that were rolled out in WA. They're very much based on the UK at that particular time. The hip fracture registry here was not mature by any stretch of the imagination, and they were able to demonstrate that they were able to improve time to surgery. And certainly when the hip fracture registry started reporting, you could see very clearly that WA hospitals were up the top for the first few years. That's very definitely now changing, and there are other states and hospitals who have upped their game and are improving all the time, which is great to see. So in conclusion, data does support the idea that adherence to our national quality indicators is directly linked to outcomes. The outcomes I've reported tonight are death and days alive at home. About 35% of patients receive care that is considered either low or moderate adherence, so there clearly is opportunity for improving. I do think Australia needs to be exploring how we reward high quality care. We have a system that penalises poor quality care or complications. The pot of money is the exact same. The way you describe it is different, and I do think we probably should be rewarding high quality care. We do need to build longer term measures that are truly patient centred. And I've presented you work that is predominantly from New South Wales, but we now have the data to be able to do that at a national level. So that will follow in due course. Thank you very much.
Thanks, Jackie. Now I'd like to hand over to Dr. Seth Tarrant, an orthopaedic surgeon from Newcastle and also a member of our Hip Fracture Registry Steering Committee. Thanks, Seth.
Thanks so much. Excellent. I believe most people can see that. My name's Seth Tarrant. I'm an orthopaedic surgeon from the John Hunter in New South Wales. The John Hunter is the largest admitter of hip fractures in the state. Thus, training there and growing up there, I've had a great interest in hip fracture quality of care. Declaration of interest, none pertain to this topic. It's mostly pertain to trauma. So Jackie's made a very important point that adherence to protocols affects outcomes. Timing to surgery has been one of the classically conserved outcomes, outcome effectors. We know that the sooner patients get to surgery, generally the better outcomes they have in terms of quality of life and also mortality, which the ASM is concentrated regarding. When I was a junior doctor, sort of working at the coalface of orthopedics early on, I started noticing things changed. And one of the biggest spanners in the time to surgery works was the introduction of NOACs, as they were called back then, now known as DOACs. They came on the PBS in 2013, and this paper from the MJA demonstrated they were quickly adopted in veterans. At the John Hunter, I saw plenty of instances of patient care being compromised by the sheer confusion over DOACs. And in 2020, we published this retrospective review of our patients that I was following quite closely, unfortunately mainly through our mortality and morbidity meeting. That was source of inspiration. What we saw in our hip fracture population was that year after year after year, the proportion of patients on DOACs increased. Back in 2011, nobody was on them. And by 2018, within a 7-year period, almost 10% of patients were on DOACs. We admit about 400 to 450 hip fractures per year. Things that I was worried about as an orthopaedic surgeon: the hemoglobin, the transfusing, both pre, intra, and also post-op, and also death. We all know as surgeons that death is a very bad outcome. When we looked at the hemoglobin, charted against the time to surgery from the last dose, so not admission, but when the patient actually had their last blood thinner, there was no statistical significance. However, we did see a little bit of a dip in the curve for post-op hemoglobins the sooner they were operated on, but this really normalised. When we looked at transfusion of red patch cells, once again, we saw there was a bit of a higher transfusion rate according to the curve when those patients had surgery within 24 hours of their last dose, but there was no significance. And we look at the very top of that chart, and there's one patient who had 8 units operated within 24 hours of the last dose, which really sort of swayed these low numbers. There was about 112 patients in this cohort. When we looked at mortality, there was a few patients, N was relatively low, but we did see that as time from surgery crept on, so time to surgery from last dose crept on, we saw there was a bit of an increase, although very wide confidence intervals. So what we could sort of note from this was that there was really no decrease in hemoglobin. There's really no increased risk of transfusion no matter when they were done. And death, whilst not significant, looked like it was having greater odds the further surgery was from their last dose. The ANZ Hip Fracture Registry sort of charted our experiences on a larger setting. We see that basically the time to surgery has crept up, sadly, over the last couple of years. And this is due to a number of factors: COVID-related, staff-related, resource-related. And as Chris demonstrated this chart, we clarify the reasons for delay. As a surgeon, how can I get these patients to theatre quickly? Well, I don't know what other means. Not known is not known. Delayed diagnosis, it's hard to diagnose earlier. Theatre availability, I don't have any control over resources. Sadly, a lot of the hospitals are at tipping points in terms of access, and centres like the John Hunter fight between paediatrics, infections, referrals from other hospitals, and also polytraumas. Surgeon availability, well, I definitely can't affect that as a surgeon. But things that I can affect, and delay due to anticoagulation, which is now 10%, it was up to almost 20% in earlier registry reports, is something that certainly we can control. And also delaying due to being medically unfit is also something we can control. And often that's code for other problems. It can also be code for anticoagulation. Across the country, Hannah Seymour, who we speak in the next group, was looking at the same thing. They're looking for reasons for delay. They looked at the 3 big hospitals in Perth. Time to surgery was far better than the John Hunter on average, and also a 24-hour time between admission to surgical intervention. However, in their DOAC group, these levels are almost twice as high, particularly when compared to patients who were not on anything, up to 44 hours. When they looked at certain outcomes, they didn't look at mortality, but however, they did look at transfusion. And there was no real difference, and this may be a factor of a delayed time to surgery as well. From the Australian experience, the Hip Fracture Registry group, including Rebecca Mitchell, who's been on many of these papers, you know, and maybe online this evening, assembled a group to look at this on a wider scale. And globally, there's 21 papers examining hip fractures and DOACs, which DOACs had delayed internationally. No one was doing a good job, which we could summate, and everybody had questions and inherent fears regarding taking these patients to surgery early on blood thinners. The course is a very heterogeneous reporting protocol for all these outcomes, so it's hard to make sense and to make any recommendations for this. At the same time, the anaesthetics community in the UK developed some guidelines. They basically said that most patients on dabigatran, which makes up a far smaller proportion of DOAC use than the other medications, could go to surgery safely within 40 hours of last dose. And rivaroxaban and apixaban, which are the main two, could be done between 12 and 24 hours of last dose. So this was certainly a relatively aggressive paper. There was not a lot of evidence which they based this upon, and this is mainly expert review. So as a surgeon, you know, it's very hard to necessarily accept or convince my colleagues based upon an expert group of anaesthetists from the UK to expedite their patients to surgery when there's concern for blood loss. The ANZ Hip Fracture Registry members and also the Fracture Fragility Network went beyond this. And over the last couple of Fracture Fragility Network meetings, we've gathered a consensus panel, put out international questionnaires, and essentially made a statement. So this is probably the overarching document, which some members from the Hip Fracture Registry are involved with, stating that peripheral nerve blocks can be safely performed. Pain management is one of the key indicators in our hip fracture registry, and often that is this concern regarding blood thinners and putting needles in thighs. But the overall consensus that this is safe. That hip fracture surgery can be reasonably performed within 36 hours, you know, which is something that we were seeing a lot of pushback from. Likewise, that GAs were safe within 36 hours and even 24 hours, and essentially these could be restarted within 48 hours of surgery. So the guidelines from 2020 by the UK, the Fracture Fragility Network guidelines, trying to find the disconnect between what is recommended and what is reality is one thing that Hip Fracture Registry is very good at doing. As Chris shown, we've done a bone protection, we've done physiotherapy, and DOACs was thought to be a reasonable thing to look at. So 31 facilities between Australia and New Zealand were recruited, and over 1,000 patients were prospectively audited over a 2-month period. And we looked at several questions, all concerning regarding DOAC last dosing, DOAC cessation, DOAC recommencement, and also some outcomes such as transfusion, which isn't normally collected by the Hip Fracture Registry. We showed that patients who were taking DOACs were older. We showed that they were more likely to be male, which makes sense given the preponderance of cardiac disease amongst men. We showed that there was a lower proportion of patients on DOACs to be ASA 1 or 2 and a high proportion to be ASA 4 or 5. And we also showed that they were inherently more frail. So this is a sicker cohort in general. In terms of the outcomes, we show, this is a bit of a busy graph, so I'll go through it. We show that essentially only 40% of patients on DOACs got to theatre within 36 hours was the recommended time. And that's 36 hours from admission, not even 36 hours from their last dose. The last dosage was recommended by the UK anaesthetic group and also recommended by the Fracture Fragility Network. So the teams in Australia, for whatever reason, are not listening or not being exposed to the international consensus guidelines, and consequently we're seeing a variation in practice and potentially increased mortality resulting from that. Patients who weren't on DOACs, we had about 2/3 getting to theatre within 36 hours. We also noted that there was no real transfusion difference between DOACs and those who are not on DOACs. So the main concern with surgeons about transfusion, maybe it's justified seeing this delay, or maybe it's not, and we'll look into that a bit further. When we look at the graphs, so this busy graph on the side, we see that patients who are on DOACs in the top Kaplan-Meier curve had significant more delays than patients on other antithrombotics, including Plavix and co-Plavix, whilst patients on nothing got to theatre in a relatively timely fashion. Looking for reasons for delay, what were the reasons for variation? We know that DOAC patients were sicker, were more frail, were older, and more male. The main driving factor, or the most significant odds ratio, was patients being on DOACs. That was the main reason in a multivariable analysis with adjustment that patients were delayed to theatre in timely fashion. Age didn't make a difference. Residential status didn't make a difference. However, ASA also made a difference, i.e. frailer or sicker patients tend to be more delayed. However, DOACs was an independent feature. When we look at timing of surgery after the last dose, we see that very few of our patients actually get there within that 36-hour recommendation by the Fracture Fragility Network. Less than 3/10 of patients on DOACs had surgery within 36 hours from the last dose. Reasons for delay, the majority was, of course, being anticoagulation, but also unfit for surgery, theatre availability, and some smaller reasons. When I go back to my original graph I did in our paper from the John Hunter, we saw that transfusion probability for DOACs maybe was slightly higher within 24 hours of last dose. However, looking at the 100 plus or nearly 200 patients on DOACs in this prospective audit, we saw that transfusion risk was not increased at any point in time. It was essentially a straight line. So delaying patients for DOACs does not decrease the likelihood of transfusion. When looking at inpatient mortality, a very hard outcome that, of course, everybody in this talk is concerned regarding, we saw that patients who were not on antithrombotics had a 5% inpatient mortality. Those on DOACs had an 8.6% inpatient mortality. Antiplatelet agents were 7.4%, and the others had very low N, so it's hard to comment on. When we're looking at the timing of mortality, we see that many were clustered within the first 10 days post-operatively, and there was a very small space. So patients who pass away as inpatients after surgery tend to do it in a relatively quick fashion, which doesn't necessarily reflect well upon the surgical decision-making or potentially the modes of care given. When we look at a multivariable analysis with inpatient mortality being the main outcome, the main drivers were cognition, followed by ASA. However, time to surgery from last dose was not significant. So time to surgery or delaying surgery for DOACs does not appear to affect inpatient mortality. It is cognition, it is comorbidities with things that we obviously can't change. So thank you for listening to that. Obviously, my take-home messages are the antithrombotic use is relatively common in patients with hip fracture, becoming more and more common. It's almost at 20%. DOAC use and other antithrombotics are still a very common reason for surgical delay, and this can be addressed based upon the evidence we generate from the hip fracture registry. Patients obviously taking DOAC are older, sicker, more likely to be men, and have a high inpatient mortality as a result. However, delaying surgery does not seem to have a transfusion nor mortality benefit for inpatient mortality. Thank you.
Thanks, Seth. Finally, I'd like to hand over to Dr. Hannah Seymour, so geriatrician from Fiona Stanley Hospital in Perth, and also has been heavily involved with the hip fracture registry for many years. So thank you, Hannah.
Thanks, Chris, and thanks very much for the invite to talk, and also giving me time at the end. It's always a risk when you're the last presenter. So non-operative management of patients with hip fracture is one of the things I get asked about very frequently. And this is an audit of surgical mortality. And when someone dies after surgery, we always worry, did we do the right thing? I have no conflicts. So this has been a study that's been quite long in the making. And like others, just really want to thank other people who were involved in this study. Carla Davis is one of our trainees, is online, as is Rebecca Mitchell, and Lara Harvey did a lot of the analysis. So that question would be something I get asked very, very regularly. We look at our patients, we look at some of our patients who are the most frail, and the question is, should we operate? And when you look at the group of patients who we care for, if you look at the most frail group, 24% of our patients are over 90. 3% are bedbound or use a wheelchair, and 40% usually walk with a frame. 25% already live in residential care when they come in with a hip fracture, and 37% had pre-existing cognitive impairment or known dementia. In Australia in 2023, 98% of all of our patients had surgery, and that includes the vast majority of this very frail group. And we all question sometimes, are we doing the right thing? Particularly when you look at mortality rate, and as has been discussed, there is a bit of variation, but we all cluster around 7% mortality rate at 30 days in Australia and New Zealand, and that is fairly consistent. I think we don't always know about other conditions, and recently we've been looking at 30-day mortality in some of our quality data across Western Australia, and hip fracture has a 6.6% 30-day mortality, but pneumonia has a 5.9% mortality rate, stroke has a 10.5%, and acute myocardial infarction is 4%, and that has reduced a lot over the last 10 years. So when you think about our hip fracture patients, one of the things we added to the registry 4 or 5 years ago was collecting a frailty scale. And for those who are unfamiliar, a lower number is better, and the scale goes from 1 to 9. So if you take our hip fracture patients, 24% are in that independent group. Another 15% are vulnerable and 19% mildly frail. Those are people who are living independently at home, maybe with cleaning assistance or shopping assistance, but still predominantly independent at home. Once you get to frailty scale 6, you're generally needing quite a lot more support at home and often needing help with bathing and dressing. And then that group of people who are frail, very frail, 7 to 9, it's impossible for those people to live independently at home, and many of them are in residential care or have a live-in carer. And why did we add that? Well, we added that because clinical frailty scale was a good predictor of mortality after a hip fracture. And when you looked at both 30 and 1-year mortality, the frailest groups, those people who are frailty scale 6 or 7, so needing help with at least bathing, have a very similar frail mortality at 1 year. And that comes to about 40% of people being dead at 1 year. And that's important because we think, well, are we doing the right thing by operating on these frail people who have a poor longer-term outcome? So in Australia, Australia, New Zealand, in the registry, we always collected the group of patients who had non-operative management, but we didn't know why people had non-operative management. And so after some discussion in 2021, we started collecting the reason for no surgery. And the 2 primary reasons are that you don't need an operation, so you have an undisplaced fracture, which you're able to mobilize on and therefore does not need fixing, or palliation, although there is this group of others that we're not quite sure about, but this was progress from where we had been. None of the other registries around the world collect the reasons for these differences, and are left really not understanding the data as well as we possibly could. So we took the data from 2021 and 2022 and looked at all of our hip fracture patients. The mortality was linked to the national mortality collections for New Zealand and the National Death Index for Australia. So we're certain about death as an occurrence. And we performed a subgroup analysis for the palliative group and when they died. So to summarise, 97.8% of patients across Australia and New Zealand had an operation. And it's pretty consistent. There is a small amount of variation, but it is pretty consistent across most sites. The non-operative rate was 2.2%, of which 0.4% were because they didn't need surgery. 438 or 1.4% of our patients didn't have surgery because they were going to be actively palliated rather than having an operation. And other reasons were 0.4%. And that's across 31,500 patients. So these are really big numbers. So what happens to people in these groups. So if you have surgery or it's not indicated, your mortality is at the top in the blue and the green lines. And going out to even 3 years, your outcomes look to be pretty similar. There doesn't seem to be a difference in mortality. The red line is the palliative group, and you can see that there is a really significant early drop-off, and patients, as you would expect in that group who are palliated, die, and they die quite quickly. But even in this very small group who are palliated, there are some patients who don't die. And in fact, only 87% of patients had died at 30 days, despite this being a very small group where we think we're good at predicting that they will die quite quickly. The palliative group, as you would expect, were older, frailer, more dependent, had a higher rate of dementia, and were more likely to reside in residential care. Interestingly, men were more likely to be palliated than women. The other group remains a bit of a mystery, and we can talk about that in the questions, but we're not exactly sure what that group is. It may be patient refusal or family refusal for an operation. Interestingly, the non-operative patients were less likely to be seen by a geriatrician than those that had an operation. I don't know if that's because people died very quickly. I think, in my experience, surgeons and anaesthetists are very good at recognising people who are actively dying, and it doesn't always take me to tell people that. The palliative patients, as you would expect, had a short length of stay, and that would fit with my personal experience, where often people from residential care will choose, they and their families will choose to go back to residential care to be palliated. It doesn't necessarily mean that everybody died in 4 or 5 days. But the palliative group did have the highest in-hospital deaths, as you would expect. So to summarise, I'm really happy to answer questions because I think there's a lot in this, and a lot of discussion often happens around individual cases and what is the right thing to do. Looking after frail older people is complex. The decision making is complex, and there are often alternate views about what we should do. Patient values and preferences are important, and I'm really happy to share some anecdotes on that. I think listening to patients and understanding what they want is really, really important. And we as clinicians have to have really good shared decision-making skills in order to really make that those holistic decisions with everybody involved, understanding what it is that particular person wants. Surgery does remain the standard of care, even for very frail patients, where we talk about a palliative operation being the standard of care, and we are very clear about how we will escalate or not escalate care after an operation. And palliation without an operation occurs in 1.4% of patients across Australia and New Zealand. Identifying those at the highest risk of deterioration and making a plan for deterioration post-operatively is really, really important. Just because we operate on somebody, it doesn't mean that we have to continually escalate care. And we know nothing about the quality of the death around either operative for palliative operations or non-operative management. And this should be an area that we consider really carefully in the future. Thank you.
Thanks very much, Hannah. James, I might hand back to you if that's all right. And do you want to chair the questions?
While people are thinking, I would just like to make 3 quick observations. Firstly, the overlap with the work that we're doing with emergency laparotomy is very similar to what you're reporting in terms of having problems with delayed theatre access, the important issue of patients who do not have surgery and how they're managed, identifying them. But what I'd like to do first is to go back to Jackie. Your work has shown that if hospitals take part in CQRs, they get better outcomes. It's the latest in a long series of articles and studies that have done that. At what point do we remove the carrot and apply the stick to actually getting hospitals to take part? When do we say there has to be real consequences to not taking part, say for a surgeon with CPD or a hospital with accreditation? I mean, you yourself have written an editorial in the ANZ Journal of Surgery questioning the ethics of not taking part. I mean, it's a serious problem that we have clear evidence that putting practice into place improves outcome, yet people don't do it.
Yeah, it's a good question, James. I personally am not someone that thinks the stick is the answer. I think clinicians on the whole switch off to financial penalties. We have them already at the moment. Most people couldn't tell you what the cost of a hospital-acquired pneumonia was in terms of the national efficient price and how much of a reduction you get. I think on the whole, clinicians want to do a good job. The registry, by measuring what's been done, helps clinicians see whether they're doing a good job or not. I'm strongly of the view that Australia should be thinking about incentivising high quality care rather than penalising low quality care. I think clinicians are more receptive to that approach. You can use the argument the bucket of money is the exact same. The way you phrase whether you reward or penalise is what makes a difference. If you want to reward, then you just reduce the national efficient price and you won't get the true cost of hip fracture care unless you actually meet those standards. But that's an incentivisation process rather than a sort of penalisation process. So I'm more on the rewarding high quality rather than penalising low quality. I haven't got the proof in this country yet, though.
Yeah. Fine. There was a question about DOACs and whether it's worth measuring the level in the serum to help expedite access to theatre. Steph, that's for you.
I think the national expert on that is in fact Hannah Seymour. In that paper that I published before, they did look at 50 nanograms per milliliter as an arbitrary cutoff, and work has been done on that within 30, within 50. DOAC excretion is variable, and the Danes have published on this. So I think holding on to arbitrary levels is just another barrier to delay. I think there's probably enough clinical evidence that expedient or timely surgery does not have any deleterious consequences. But I'll be interested in what Hannah's response was at, because they did prospective research on that.
We did, and Denise was, I know, is also from Western Australia. We're about to move away from measuring levels. It's quite hard to stop measuring them when you start. I'll just put that out there. There is very little international literature. I think it was something that we tried early in the piece when there was a lot of variation to try and increase the number of patients who could get early surgery, but there is a lot of variation. I think 50 is even too conservative. If you were going to pick a level, I think now it would be close between 75 and 100, but we're about to stop measuring levels because I think there is no international literature on them and there is no evidence that they make a difference.
Another question in the chat room is whether there's concern about patients who don't have a hemorrhage but ooze, and whether that then leads to a wound infection and wound breakdown.
Yeah, obviously, the fracture-related infection and infection of arthroplasty in hip fractures is probably around, for deep infection, it must be around 3%, which is double from an elective arthroplasty cohort. So obviously, while still is concerned, it's still a relatively rare consequence. Whether or not these patient cohort will be followed up regarding that, from the sprint audit, no. If we were to do this, we'd have to, which is not unreasonable, but follow up those individual 180 patients minus the 8% inpatient mortality. But even then, the numbers, in order to define a timeline, would be, I think, relatively low. Yeah, but these are just overarching views as well of our patient cohort. Obviously, precision-based medicine is imperative, and so if patients feel that restarting DOACs early increases wound breakdown and infection, then of course use your own clinical judgment. Likewise, I don't know how many of these patients would have either thromboembolic events from not having their DOACs restarted. I think it'd be relatively rare. We know MI after hip fracture is about 3%. DVT is rare, as is pulmonary embolus. So I think there's probably a bit of a safe window to restart DOACs. That's my opinion. I'd be interested to see what other people's opinions were, particularly Chris's.
I use sort of Clexane post-operatively and then restart DOACs at 48 to 72 hours as long as the wound's okay.
Yeah, I think the international consensus was most people were actually restarting at 48 hours. It always comes down to individual care. Why are people on DOACs? But most of our population are on a DOAC for atrial fibrillation, and the perioperative risk is relatively low. So it does come down to individualized recommendations. There's also should be consideration of is a DOAC still appropriate? So in incredibly frail patients, there is a question mark about whether they still are the right thing to do. And so often the geriatricians looking after people will consider, is that the right thing to do? Is it the right thing to do straight away? And are they on the right dose? So I think there is a bit of complexity about restarting that should be considered. It isn't just as simple as they came in on one, they should go home on.
You also have to think from a patient perspective. So yes, surgeons are worried about an oozy wound. If you said to a patient, which would you rather have, a stroke or an oozy wound, most would opt for the oozy wound. You've only to see 1 or 2 strokes that occur post-operatively to realise you are wanting to get people back on their DOACs as soon as it's safe. I think most people these days are going to around 48 hours.
We've got another question in the chat room about balancing the care of patients who have surgery, getting them to theatre in time, and those who do not have surgery, making sure they get the appropriate care. And I think, Hannah, you touched on that when you talked about providing multidisciplinary input.
Yeah, look, I think our pathways are what delivers the high quality care to most people. I think it's always important to think about that very small group of people who are truly actively dying. And the evidence is, I think, from our study that we're all pretty good at recognizing that. And if you're not actively dying, which I think is how most people describe the group who we should be palliating and are quite clear, then the evidence is that you will have a better mortality outcome from an operation. However, that might not be the most important thing. But I think what we also know is that death is much less predictable than we think when we palliate patients. So these are really complex decisions. And I think the majority of us are doing actually very similar care when you look at the data overall, although there is some areas of variation. And I think at the moment, I don't think that anything I've seen would change my practice. If I walk into the room and I think someone is actively dying, then I think they should be palliated. There are a large number of people who are very, very sick. And I can give you multiple anecdotes. We've had a run on people who, with end-stage renal failure, creatinines of 800, who chose not to be dialyzed, who said quite categorically, I want an operation. I don't want to lie here and die. And surprisingly got through an operation and home pretty quickly. So I think we are less good at predicting comorbidities and what's going to happen than we think. And if patients want to have an operation as part of their end of life care to maintain independence, which is incredibly important to people. If you don't operate on a hip fracture, you can't get up and you can't have a shower, never mind get to the toilet. And that means that your life is really, really limited. So I think nothing that I've learned has changed my view about this. And I think unless you're actively dying, an operation is still probably the best way to manage your quality of life after a hip fracture, even in the frailest group. I think the others, if you're not frail, absolutely have an operation every single day of the week.
I think it's a very important issue, and there's much overlap with emergency laparotomies. And I think one of the issues that is different between Australia and the UK is the transfer rate. What happens when patients get transferred into major centres? Because often they're travelling huge distances and they lose contact with the surgeon who looks after them, which can only make things worse. But I think an important advantage of having a meeting like this is that we can see the overlap, and obviously the common ground is the care of the elderly patient, the assessment of frailty, the involvement of the geriatricians.
I think the partnership is really important, James. I think, I've learned an awful lot about orthogeriatrics. I know very little about caring for people after laparotomies, and the care is very different. Most hip fracture patients come back to the ward. We very rarely send people to ICU. So I think it is very different, but you only learn by collecting this information. And what you can do with registries is ask questions and over a long period of time, try and gather the information to answer them. And that I think is really valuable.
James, do you mind if I just quickly make a comment on the transferred patients? I think you raise a really important point. So particularly for us in the regions, up to 40 to 50% of my patients are transferred in from peripheral hospitals. And that does affect our ability to get them to surgery within 36 hours. But what we've done in Toowoomba is established a rural NOF pathway to ensure that all of our rural hospitals are initiating appropriate care pre-surgery early on, so that we're ticking those other indicators on the clinical care standard, so that by the time the patient gets to Toowoomba, they're essentially ready to go to theatre straight away. And that's been really successful and something that we've shared to other facilities around the country. And that might be something that's worth looking at for laparotomy patients as well.
Yeah. We've been asked a question about whether the post-operative hemoglobin is a consideration when restarting DOAC. So if the hemoglobin's low, do you delay starting the DOAC? Steph, I think there's one for you.
Yeah, I was considering the answer. Sorry, I was deep in contemplation. Most hemoglobin normalizes sort of by day 5 in the studies that looked at transfusion. Yeah, I certainly think that if someone has a low hemoglobin and you're not entirely sure what is the cause of that, obviously initial blood loss from the blood thinner and obviously the surgery itself are the main 2 culprits, then I would hesitate starting something that is not easily reversible and that something has a long half-life. So obviously I'd go to low dose of heparin or a heparin infusion if you were really concerned. I think that's just sort of common sense medicine. If somebody's still potentially actively bleeding, do not start an irreversible or a very expensive reversible agent.
One's just come through. Does any institution use aspirin for their DVT prophylaxis?
What a nice easy one to finish on.
We could get Professor Harris to talk about his study. I personally use aspirin a lot for 6 weeks due to a multitude of reasons. But I don't speak on behalf of my institution. We have 20 orthopaedic surgeons, and I think I just feel very strongly about Clexane.
I don't think there's evidence to support the use of aspirin as DVT prophylaxis in a hip fracture population. There we are. Seth and I have completely opposing views there.
Hannah, do you want to say something there?
Oh, well, we use Clexane for inpatients and aspirin on discharge. So we do a bit of both.
Yeah, then that's what I do. But 30% of our patients are on aspirin to begin with, and I really worry about loading up anticoagulants and antiplatelet agents in patients. Anecdotally, I've seen gastrointestinal hemorrhages from people on 3 antithrombotics. I'm not. Maybe I need to revisit the evidence pool. Jackie's making me feel bad.
That's not the intention.
I think, James, going back to the question about registries, I think registries do answer all the little things that you do as an institution. So we do have 30-day mortality and 120-day mortality by the institution. And if you have a standard of care at your institution, you will know what your mortality is compared to others. So if there were really big differences, I think we'd be seeing them.
Yeah. Okay, well, we've got no more questions and we're just on the hour. So I think I'm going to wind this up. I'd like to express my sincere thanks to Chris and all the speakers for taking up the challenge and talking about this. And I'm a great believer in clinical quality registers, and I commend the hip fracture audit for all they've done and showing the leadership in this area. And I think that's come out tonight. So thanks for the attendees. Just to remind you that this will be recorded and will be placed online for you to access in due course if you want to go back and have a look. And thanks very much to the rest of you.